Okay, like in all the other chapters dealing with specific joints, we're going to talk about functional considerations, mostly having to do with balance of muscle forces in the knee. And so what, right? This is the so what part. So what do we know about this, and how does this affect how we're doing anything? So for the learning objectives, I want you to be able to analyze lever relationships given functional motion at the knee. And usually we're going to be talking about, when we're talking about functional motion, we're talking about sit to stand, walking, good old function. We like that. I want you to be able to identify positions of active or passive insufficiency for any multi-joint muscle that crosses the knee. So most of the multi-joint muscles that cross the knee also cross the hip, and some of them cross the ankle. So one of the ways to think about it is if you have a multi-joint muscle like the gastrocnemius, or the hamstrings, the position for passive insufficiency is going to be equivalent to a stretch for that muscle. So think of your calf stretches and your hamstring stretches, and that gives you the position for passive insufficiency of those muscles. So that's half the question right there. I want you to be able to identify the potential underlying causes of patellofemoral dysfunction. And we're going to talk about a couple of them. And then you get to explore some of those in class as well. This learning objective, identify the muscle credited with unlocking the knee or initiating knee flexion, was also in the muscle section. We know it's the popliteus, but we'll just talk a little bit about that in this section too. So lateral tracking of the patella increases pressure and friction within the patellofemoral joint, and it may result in pain, inflammation, joint degeneration, or even patellar dislocation. So we generally classify factors that contribute to lateral tracking as intrinsic or extrinsic, and that helps us determine more effective treatment strategies. So if it's intrinsic to the knee, it has to do with the knee itself. If it's extrinsic, it might have to do with the neighboring joints, like the hip or the ankle or the foot. So this diagram from the book shows some different intrinsic and extrinsic causes of lateral patellar tracking. So intrinsic factors are things that are in the knee itself that are going to cause that. So weakness of the vastus medialis, or sometimes they talk about the vastus medialis obliquus, VMO, which is the portion of the vastus medialis where the fibers run obliquely, sort of just medial to the knee. So if those are weak, compared to the vastus lateralis, you can have lateral tracking of the patella. Hypertrophy of the vastus lateralis also can cause that lateral tracking because the lateralis is stronger than the medialis, and you get the lateral tracking. If you hear something in the background that sounds like a dog drinking water, it's Tessie drinking water. So another intrinsic cause to lateral tracking of the patella could be a tight iliotibial band or tight lateral retinaculum. So a lot of times we'll do manual therapy. So I'll do instrument-assisted soft tissue mobilization on that lateral retinaculum or tight iliotibial band. And they call it a bowstringing force on the patella. So you can imagine if the IT band is like a bowstring and you're pulling back on it, it pulls the patella laterally. So extrinsic factors contributing to excessive lateral tracking of the patella could include weak external rotators or abductors of the hip, internal rotation of the femur. A larger Q angle can contribute to lateral tracking of the patella, relative external rotation of the tibia on the femur, and pronation of the foot. So all of those things are not really having to do with the knee itself or the knee muscles, but they can all contribute to lateral tracking of the patella. So those are definitely things that we want to consider during therapy. So do we need to treat the weak hip external rotators? Probably. Do we need to treat the weak vastus medialis? Probably. Do we need to treat the tight iliotibial band or lateral retinaculum? Probably. Do we need to get them in some orthotics to treat the pronation of the foot? Maybe so. Can we do anything about the internal rotation of the femur? No, we cannot. Nor can we do anything about the external rotation of the tibia or the larger Q angle. So some of these things we can treat, some of these things we can't. You have to tackle the problems that you can handle. Okay, what else can affect our patella? So besides lateral tracking, patellofemoral joint pain is often characterized by the inability of the patellofemoral joint to tolerate large compression forces. So one of the things that I swear I work on it every day in the clinic is functional squatting, is what we call it. So we want to avoid squatting motions to limit excessive compression and damage to the patella. So when you look at this diagram here, it shows how if you squat down and your knees go forward, go anterior to your ankles, it puts excessive compression forces right in the posterior part of the patella. However, if you make it what I call a functional squat, and I didn't make that up, we all call it that, and you take your hips back, you can take some of that excessive pressure off the patella. So I'm always coaching people in that functional squat. You can try it yourself if you stand right close to a wall so your knees really can't go forward, and try to squat down and keep your balance. You'll notice that you have to shift your center of gravity back by taking your hips back in order to maintain your balance, and there's not a lot of pressure on your patellas. So rather than avoiding squatting, we want to do it in a functional and non-damaging way. So often due to spasticity or muscle irritability or spending an extended time in a flex knee position, so someone who uses a wheelchair for mobility, someone who's just sedentary sits a lot, someone who has to study a lot of kinesiology and has to sit while they're doing it, spends a lot of time in a flex knee position. So we can all have tight hamstrings. Tightness of hamstrings is often visibly observed by an inability to fully extend the knee. So extreme hamstring tightness may also lead to chronically flexed hips and a posterior pelvic tilt and a flattened lumbar spine. So that's one of the things that we can work on is hamstring length. I always say everybody needs to stretch their hamstrings, and everybody needs to stretch their gastroc too, and probably their soleus. So the tightness of the hamstrings can be a reason why people have pain. So here's an example of use of kinesiology in the clinic. So I was working with a patient after their total knee replacement, and she was doing really well, getting her range of motion back and getting her functional activities back, but she was experiencing a lot of pain in her medial knee. So I asked her to point, and she said it was a pretty concentrated area of pain. So I asked her to point where the pain was, and she pointed to basically the anteromedial aspect of the proximal tibia. And we all know what attaches there, right? The gracilis, the sartorius, and the semitendinosus. So I palpated a little bit and through those muscles, and it turns out she actually had a semitendinosus strain. So we worked on some gentle stretching, we worked on some manual therapy, and it helped a lot. So kinesiology saved the day. So I was able to treat that specific muscle because I knew the origins and insertions of the individual muscles. So a lot of times before knee surgery, Someone can't fully extend their knee, and so some of their muscles are in a shortened position for a prolonged period of time. And then after knee surgery, you've got, they corrected the knee problem. So now you've got muscles that weren't on stretch before, and now they are on stretch. And so you might have some muscle strain involved with that, and you might have to work through that in your recovery from your total knee replacement. So knowing where the muscles originate and insert, really important for treating those muscles. The other thing that happens with tight hamstring, if you have passive tension in the hamstrings, it can posteriorly tilt the pelvis. So we talked in the hip chapter about anterior and posterior pelvic tilts, and the hamstring group, the hip extensors were part of the force couple for that posterior tilt. The pelvis needs to be stabilized as you perform that hamstring stretch, so you can stabilize the origin, the ischial tuberosity, and stretch the hamstrings. Excessive posterior pelvic tilt may produce unwanted overstretching of connective tissues in the lumbar region. So a lot of times if we're dealing with people with disc issues, we want to keep our neutral spine, which is a little bit of lumbar lordosis. So tight hamstrings can contribute to pressure on the discs by decreasing the lumbar lordosis. So that is one of the functional considerations of tight hamstrings. So most lower extremity activities combine hip flexion and knee flexion, or hip extension and knee extension. And a lot of times they're in opposition. So we're doing things that have hip flexion and knee extension. Combined hip and knee extension, both the rectus femoris and the semitendinosus avoid maximum shortening across the hip to prevent muscles from becoming actively insufficient. So in the position where in this diagram, the hamstrings are actively overshortened and the rectus femoris is passively overstretched. Most of our functional activities avoid that by having opposite motions at the hip and the knee. So that's something that we're going to look at a lot in the lab, active and passive insufficiency of all the different multi-articular muscles. So think about functional movements and think about how most of our functional movements intentionally avoid active and passive insufficiency of those multi-joint muscles. So the hamstrings, the gracilis, the popliteus, and the sartorius control active rotation of the knee within the transverse plane. Medial, and by active, we don't necessarily mean voluntarily, we just mean they're activated by muscles. The medial hamstrings, the gracilis, and the sartorius internally rotate the knee, whereas the lateral hamstrings externally rotate the knee. And we're talking about the tibia internally rotating on the femur, or the tibia externally rotating on the femur. The internal rotators of muscles of the knee far outweigh the strength of the external rotators. So hamstrings, gracilis, and sartorius far outweigh the strength of just the lateral hamstrings, just the short and the long head of the biceps femoris. So it's thought that the stronger internal rotator muscles reflects the need to either accelerate the knee into internal rotation by concentric contraction, or decelerate external rotation by eccentric activation. So that's part of the stability in motion with the knee. So a lot of our muscle balances actually balance the stability in our joints. Kind of interesting. So the stability of the knee, it's maintained largely by ligaments and connective tissue and the surrounding muscles. The combination of large forces that go through the knee, compressive forces and shear forces, and lack of bony constraint may be the reason that we have such a high incidence of knee injuries and the way we use our knees. Rehabilitation approaches usually involve intrinsic strengthening of the knee itself, as well as extrinsic, the surrounding joints and muscles. So a lot of times when we're doing knee rehab, we're not just working on strengthening the knee, we're also working on strengthening the hip and strengthening the ankle and working on stability and mobility in the entire lower extremity. So if no matter what setting you work in PT, you're always going to be working with people with knee injuries. Sometimes I'll say if we walked around on our hands, we'd probably be working more on elbow and shoulder injuries. But since we walk around on our feet, it's hip and knee that we're working on a lot.